Okay, so today we'll be doing a thyroid examination. So let's see how to examine a thyroid case for surgery. Okay, so what will you start with? So of course, generally introduce yourself and try to build a rapport with the patient first.
Hello, my name is Gaayatri, fourth year medical student. So today I'm going to examine your neck. I'll be checking for thyroid swelling and anything. Is it okay for you?
Yeah, definitely.
So may I know your name?
Hi, my name is Rishee.
Okay. So first we have to look for patient's bill. How the patient is looking? The patient is looking average bill. For like thin bill means like it could indicate hyperthyroidism.
Okay, thin build, so hyperthyroidism. Okay, yes. So the first thing, we look at build of the patient. What if he's overweight? He appears overweight.
Could be hypothyroidism.
Hypo, yes. Or it could be euthyroid if you feel that he's not over or even too thin. And anything else that you want to inspect? This comes under relevant general inspection that you have to do. So anything else relevant?
We have to check for the hoarseness of voice.
Yes, so you got to check for his voice. So that's one reason why we asked him a few questions, asked the patient a few questions, so that we can have an understanding, we can hear him speak.
You could elicit any damage to the recurrent laryngeal nerve due to any infiltrations.
Okay, so what will that present the voice with?
Hoarseness.
Hoarseness. So hoarseness can happen when there's damage to recurrent laryngeal nerve due to infiltration. There could be many causes, damage, surgery. But here we want to know if it's, because we're interested to know if that swelling is malignant. So if there's malignant infiltration to the nerve, then they can present hoarseness of voice. So how will someone present hoarseness of voice?
I am Batman. Usually they'll have that kind of voice.
Okay, there's hoarseness, okay? Very hoarse. And what about hypothyroidism? Any voice in particular?
Low pitch.
Low pitch. Okay, sometimes nasalized low pitch. Is that an example?
Lifetime settlement. Something like that. So it'll be easier for you to relate, because this is a very popular actor's voice.
Okay, so voice, yes. So look for the patient's build, then listen to the voice, and
then we have to assess for the mental status of the patient.
Yes.
We have to check whether the patient is agitated or irritable or anything, which could indicate hyperthyroidism.
So how would someone be anxious? Yes. Restless, irritable. Okay, then what about hypo? How will the patient?
Low mood.
Slow mentation. So how will someone present slow mentation? Pakcik, tak makan hari ni? Okay, so slow mentation will be in hypo.
Yeah.
So that's the relevant generals that you do. So we saw build, we looked at the patient's mental status, mentation, and also we heard the patient's voice. And anything else that you want to do before we start inspecting the anterior neck?
We have to look for any bony swelling, especially on the forehead. Do you know why we're looking for the swelling?
So probably if we suspect any follicular thyroid CA, so we can look for any bony swelling.
Yeah. So this is not something which is commonly done, but it's interesting to do because
due to its hematogenous spread.
Yes. So follicular thyroid carcinoma has a specific hematogenous spread. It commonly spreads through blood. So at times, due to the hematogenous spread, it can spread to bones. This is why it's common to get pathological fractures in follicular thyroid carcinoma. So similarly, just like any bone, sometimes it can just go to the forehead. So it can have a neck swelling and swelling over the forehead, indicating that's a bony metastasis. And after that, we would want to sit and inspect for the neck. But before we do that, we want to get good exposure of the neck. So what will we do? We'll ask the patient to remove a few buttons. If it's a female patient, then we would want to ask them to remove any scarf which is present. And before sitting, just have a general inspection around the neck, because at times they may present with some scars. Okay, so just inspect around.
Upon inspection, there is no obvious scars or any distended veins.
Okay, both sides. Okay, just make sure there's a good exposure under the shirt. Okay, sometimes there may be scar. Okay.
Bleeding or discharge.
Yes, and then you can sit. You can either sit on a chair if it's present or squat. Make sure your line of sight is in line with the neck. Make sure you do that. Okay, make sure to go out of your comfort zone. Make sure squat if you need to. But if there's a comfortable chair, and you can sit and inspect.
Now we have to inspect for the swelling. we have to align our eyes with the swelling and then see whether there is bilateral or unilateral swelling. And then have to look for the site, whether it's
Site.
anterior, posterior, triangle,
Okay.
not.
So the first thing, like what you said, the line of sight must be in line with the anterior neck. So remember, if you don't have a chair, don't hesitate to squat. Showmanship is important, and of course exposure, good exposure. So you want to start with a number. How many swellings? The solitary, multiple, like what you said, if it's
Multinodular.
Yeah, multinodular or bilobular. Okay, and then site. So whether it's anterior neck,
Posterior.
triangle, anterior triangle, etc. And then
Extend.
So is it extending beyond? Yes, beyond the midline of the neck, and then
Shape.
Shape.
Look at the shape.
shape. So what can you comment on shape?
Whether it's butterfly shape,
Okay.
bilateral.
Okay, shape, and then
skin color, like whether there is straightness or
skin changes. Yes, any redness. Okay, anything else?
then there is scars,
Scars. Yes, anything else?
and discharge
Yes,
bleeding or anything.
yes, exactly. Okay, skin changes. So maybe number, site, size, extent, and
Skin changes.
skin changes. And then what else would I want to? Any maneuver that I want the patient to do? Not
Just ask
maneuver.
the patient to drink water.
Drink water. Okay, so drink water. What's the rationale behind it?
We want to see if the swelling moves with deglutition.
Okay, so if there's a glass of water, you can ask the patient to. So how will you instruct the patient?
Just ask the patient to protrude the tongue first, and then
Swallowing.
then swallow first, and then see whether there is like swelling moving upward. or not.
So one way would be, so we don't want the patient to immediately just take gulps of water. So ask him to take a sip and contain the water in his mouth. And then ask him to hold the water in his mouth and then look at the neck and tell him to swallow. Okay, pakchik talan. Then see if the swelling moves with deglutition. Means if it moves with swelling, it means it's thyroid. Okay, so example. Okay, so instruct the patient in Malay preferably.
Tak apalah,
Pakcik.
minum saja. Saya minum saja.
Tak boleh minum. tak boleh minum.
Tak ada
Pak.
masa ni.
Yeah, minum
Okay.
and contain the water in your mouth. Okay, and then
Swallow slowly.
okay, so see if the swelling moves with deglutition. Thyroid swelling will move with deglutition. Anything else that we want to do? What other swelling can you get? Let's say if you find a rather small swelling, probably above the hyoid bone. You want to think of thyroglossal cyst. So how can thyroglossal cyst be confirmed?
Protrusion of the tongue.
So ask him to
Protrude.
okay. So when he protrudes, what do you? There's two things that you can note for. What are they?
We have to check for the swelling of the tongue.
Okay, swelling of tongue. Why? Where will tongue swelling come?
Hypothyroidism.
Hypothyroidism. HYPO.
Hypocalcemia.
Anything else? So if the swelling moves with the protrusion of the tongue, it means it's a
Thyroglossal cyst.
thyroglossal cyst. Many are not just thyroglossals, but for now, it's something important you have to keep in mind. Thyroglossal cyst. So now, after inspection, we are going to palpation. So palpation must be done from the back. So the first thing before we palpate, since you are already at the back, we want to look for proptosis. So how will we do that?
We have to look for the
Yeah. So if your height is not convenient, don't provide discomfort of the patient. You can slowly extend the patient's cervical spine. So how will you look for proptosis?
supraorbital ridge.
So see, so from above, you can look at the supraorbital. This is a supraorbital ridge. Okay. See if the eyes is going beyond the supraorbital ridge. So can you see if the eyes are going beyond the supra? So there's no proptosis. So there's proptosis or exophthalmos. You will notice that the eyes will like bulge out to a point where you can see the whiteness beyond the supraorbital ridge. Okay, the supraorbital ridge. Okay, next I want to palpate for the warmth. So how will you palpate for the warmth? Yes, okay. Make sure you use the dorsal aspect of the palm. Okay, go palpate. Okay, probably at the anterior neck. Okay, look for any warmth. Okay, and then now we want to palpate. Yes, palpate. So how the first thing is you pinch the skin to see if the skin is attached to the swelling.
Skin infiltration.
Yes. Okay. So visualize. Imagine if there's a swelling. This is how you. Okay. So you just pinch. Okay. See if you can get above the swelling. Okay. So if the skin is attached to the swelling, it means that it has infiltrated to the skin. So just do. Okay. Yes. Yes. Okay. And then what do we want to do? We want to palpate for the swelling to look for, to reconfirm the size. Okay, and you want to also look at the consistency, whether it's hard, firm, or soft. We want to look at the surface to see if it is smooth or multinodular.
On the mobility.
And then we want to confirm the shape, the margin, and also we want to see if we can get below the swelling. Again, mobility. So to palpate for the size, shape, margin, and consistency and surface, we stabilize one lobe. So it's the thyroid swelling will be in butterfly shape, right? So you stabilize, means you push one lobe and you palpate. Okay. So okay, you can do.
To stabilize one side.
Yes, and you palpate.
Palpate and look for.
Okay, so you palpate for that. You confirm the size. So what the size could be in dimension? How many cm by how many cm? Maybe 5 cm by 6 cm, etc. And then consistency, if it is
hard, soft,
firm or soft. So how will you know if it's hard, firm or soft?
The classical.
Yes. Okay. So if upon palpation, if it feels like your forehead it is hard, feels like your nasal septum it is firm, your lips don't touch it. Lips it will be soft. Okay. And surface. So what's the surface? Is it smooth or multinodular? So if it's smooth, just is smooth. Margin, is the margin well defined? Okay. And while you're doing this palpation, while you stabilize one lobe and palpate for the other, let's say patient has stridor. What does it mean?
Cautious sign.
Cautious sign, yes. Next, how will you palpate for mobility?
Okay,
Mobility.
So for mobility, we have to, I think,
yes,
we have
exactly. So you have to put your hand on the
sternocleidomastoid mastoid, and then we have to
ask him to go against the resistance provided by the hand, and then you hold the swelling, see if it's horizontally mobile, see if it's vertically mobile. Okay, can you do it? Yes, exactly.
Then if there is a swelling, then you have to check
See if it's vertical and horizontal. Yes.
Okay.
To see if it's any attachment to the muscle. And you want to, so on inspection, we check if the swelling moved with deglutition. We can replicate the same thing in palpation. So we want to see if the swelling moves with deglutition to confirm if it's thyroid. So how will we do that? So you put your fingers below the swelling and ask the patient to drink water. See if you can get below the swelling the moment the swelling moves. Okay, can you? Okay, both. Okay, and you swallow. So see if your fingers can get below the swelling. If you can get below the swelling, it means it
thyroid
moves. Yeah, it moves with deglutition. Okay, that's what you palpate from. Yeah, and then what else do you want to palpate for?
To look for the
carotid
pulse.
Carotid pulse. Yes. Okay. So how will you palpate the carotid pulse? Okay. So any surface anatomy. So it is at the anterior part of the
anterior cervical triangle.
Anterior. Okay. At the angle of mandible.
Yes.
Okay. So anterior part of the sternocleidomastoid at the anterior triangle. So don't palpate at the same time. Palpate both carotid pulse at the same time, one by one. Okay. Show the examiner that you're palpating. Okay. Palpate.
Okay.
One. So what will you comment on the pulse?
Carotid pulse is palpable, good for you.
Okay. And also mention if the carotid pulse is deviated. So sometimes you can get displaced. Yes.
Displaced.
Okay. And importance is you must mention if the pulse is palpable or not. Don't talk about rhythm, rate.
Yeah.
No. Okay, if it's palpable or not, because if it's not palpable, it's a positive Barry sign. Okay. So Barry sign, infiltration.
Yeah.
Okay. So this is Barry sign positive. You can feel for the pulse now. So it is Barry sign negative. Yes. Okay. Then lymph node examination.
Okay.
So you want to palpate. Why lymph node examination is important? Because in papillary thyroid carcinoma, 80% of the thyroid CA cases are papillary, most common. Yeah. Papillary thyroid carcinoma commonly spreads to it has lymphatic spread. So it will commonly spread to the lymph nodes, unlike follicular thyroid carcinoma, which has hematogenous spread. Papillary you have because most of it typically affects young age group, females, and it's 80%. Okay, the prevalence is 80%. Okay, can you palpate for the lymph nodes?
To start with submental.
Yes. Okay.
Submandibular.
Preauricular.
post-auricular,
post-auricular,
occipital,
occipital,
then jugular.
okay, so supra, middle and infra, jugular chain. And there's another name for it that you know.
Even anterior cervical triangle or posterior cervical triangle, yeah.
Lymph node, okay.
Lymph
And
node.
then
Supraclavicular.
supraclavicular, yes, very good. So
Then
you
if
have
you couldn't
to,
feel the lymph node, then you can ask the patient.
so shrug the shoulder. Sometimes it may be a bit difficult to palpate on patients. So ask the patient to shrug the shoulder if you can't get the supraclavicular fossa palpate. Make sure you look for supraclavicular lymph node also. So that's lymph node examination. So after palpation, now we move in front and look for percussion. So another thing, when you move in front, just now we palpate for the dimensions of the swelling, mean the size, right? How many cm by how many cm. You can confirm that by using the measuring tape when you go in front.
Yeah.
Just confirm the
Swelling.
measurement.
Yes.
Okay.
So
And then
Continue with the
percussion.
percussion of the for retrosternal dullness. Okay.
To any indication of any infiltration.
Okay. Yes. Okay. Okay. So how will you do percussion? What's the right method to do?
So ideally, what we have to do is we have to place it like this. We have to use our middle finger to hit on the phalanx, middle phalanx. So what we do is should not exceed more than 2 hits. You can do it a couple of times, but you should not exceed 2. Meaning just 1 2, 1 2, just 1 2. But you can go again to elicit the proper sound, whether it's totally dull, resonance, anything. But it shouldn't be like 1 2 3 4, 1 2 3 4. Because you have to make sure that you have to
Specifically middle finger.
you have to make sure the patient is comfortable and not in pain. Because doing this, you're going to put the patient in agony.
Okay, now we have to continue with the auscultation, where we'll be using the diaphragm to see the thyroid, and also we have to use the belt to see if there's any kinetic breathe.
Okay. And then anything else that you want to, since we have already done the stats, anything else that you want to do?
We have to check for the
Apex, yes. It's important to see if there's any displacement of apex bit. Why?
Cardiomyopathy.
Okay. Hypertrophic cardiomyopathy can happen.
So ideally, it should be in the 5th intercostal space, mid-clavicular line.
Okay, see if it's a displacement. I think India.
Yeah, I think somewhere here, about here.
Okay.
Yeah.
Okay, next.
So ideally we have to perform the tracheal deviation. So do you want to do?
Sure. So ideally, we have to adequately expose the patient, so not to get access to the heart, but to the trachea. So we are performing a tracheal deviation. So we have to first locate the sternal notch. As you know, this is the jugular notch, also known as sternal notch. This is the angle of Louis. So just for the sake of surface anatomy, so just place your forefinger and your ring finger on both bony prominence of the sternal notch. What you have to do is to just gently look for any grooving on both sides. So the logic is, if the trachea, suppose the trachea is deviated to either side, there will be a huge grooving, or there will be a hollow space here which you can palpate. That's the simple idea of checking for a tracheal deviation. Nature of performing a tracheal deviation. Thank you.
Okay. So next, eye signs, very important. So you want to start with lip retraction. So
Please remove your specs. Okay, we have to see for the lid retraction whether the limbus is, look at the limbus, and then whether the
okay, so the upper limbus, see if the upper limbus is visible. So what we mean by simple term, see if the white sclera above the upper cornea is visible. So right now we can't see anything, right? So that means the upper limbus is not visible. So there's no lid retraction. If it's lid retraction, then we will be able to see the white sclera above the cornea. Okay, that's what it means. Next, we want to look for ophthalmoplegia, which will be there in hyperthyroidism. Okay, so how will you do?
So you have to do H test. So look at my finger. Then follow this.
Okay.
We should not cross the midline because we're not
Checking for this.
checking for nystagmus.
Okay. Okay, also we want to check for diplopia also. So Diplopia, where will you specifically do? So when we do the H test, at the top here, you ask the patient, okay, how many can you see?
2.
If he says 2 is diplopia, but how many can you really see?
Nice, really can see 2. This one.
Okay, yeah. So usually ophthalmoplegia will be more prominent in this movement because it will affect the superior oblique muscle and lateral rectus. Okay, remember SO6 SO4 LR6. Remember SO4 LR6. So they will usually have pain to a point where they can't follow the finger when you move in a H direction, ophthalmoplegia. And as what Gaayatri said, make sure that the finger doesn't cross the midline. It should be just H direction here. Use the other finger and check for the other eye. Okay. Next, we want to look for lid lag. So what lid lag means is basically when the eye moves. See, now move your eye upwards, downwards. You can see that the lid moves with the eyeball. Lid lag means the lid lags in movement. So you will see the eyeball moving, but the lid moves slowly. How can you do? Put your finger horizontally and, okay, see my finger. See, it's a lid lag. Okay, do it on the other side. Okay, so there's no lid lag. Okay. Then inspect for also periorbital chemosis. So what's the easiest way to look for chemosis?
What do you do after a breakup? You cry.
Watery eyes. Okay, watery eyes. Just look if there's any watery eyes. Okay.
Next, we have to check for the hands, whether the patient's having any sweaty palms or not.
So look and also touch to see if it's sweaty. Okay, and then
we have to see if there is any palmar erythema.
Palmar erythema. Okay, and then
clubbing.
Okay, thyroid acropathy. Okay, thyroid acropathy.
So must be like eye level and then see whether the patient's having any clubbing or not.
Look at the lobby bone angle. So is it advisable to do Scamrod's window?
Usually when we're in the hospitals, people will be having IV
cannula
and
lines,
everything, and they'll be in pain sometimes when they have shoulder and everything. Can't expect them to be able to perform this.
So yeah, even I would preferably
use the
lobby bone angle. And then
you also can check for aneuploidies. Like in hyperthyroidism, there will be nail detachment.
Okay.
So
fine tremor.
And then fine tremor.
tremors.
So how will you look for fine tremor?
Okay.
Put a paper. So ask the patient to extend, and on the dorsal aspect of the hands, just leave a paper and see if the paper actually moves. Okay, this is an example of fine tremor. Okay, without fine tremor. Okay, so just look if there's any fibrillation, and then read it for the palpate for the radial pulse. Okay. Yes. So radial pulse, why radial pulse?
Probably atrial.
in hyperthyroidism, the pulse will be higher compared to normal.
Okay, yeah, tachycardia, exactly. You calculate the rate, and then irregular rhythm in atrial fibrillation, for example.
Okay.
So you want to look at the rhythm also.
Okay.
Rhythm. Okay. So next, what will we want to check for?
For proximal myopathy.
Proximal myopathy. So for convenience sake, we'll look at upper limb. Lower limb also we can do, but upper limb. So we want to check for the shoulder abduction and shoulder adduction.
So this is
Now one. Okay. Adduction. Okay. So proximal myopathy, you want to look for it. Next, lower limb.
Okay.
So lower limb, you want to look for.
Reflexes and prepetal myxedema.
So we'll start at pretable myxedema. Okay, how will you check for pretable myxedema?
Usually we have to press on the mid-shin if it's grooving.
So yeah, palpate, just like how we check for edema. Okay. Just look.
It's pitting or not.
Yes. And also on inspections, you can look for skin changes in relation to pretable myxedema. Something very important when you palpate at the shin, make sure you look at the patient's face. It can be very painful when you palpate on the tibia. Okay, painful.
No, it's okay.
But it's painful.
Yeah,
it's painful. Okay, so make sure you be careful and make sure you look at the patient's face to look for tenderness. Okay, make sure it's not too painful for the patient. Okay, then you want to look for reflexes, lower limb, knee reflex, and upper limb biceps. So how will we look for reflex? Very simple. I've explained this in separate videos. So most of the knee reflexes videos that we have uploaded, we show the patient supine. So he'll be sitting here. So when you want to check for reflex, make sure you hold the tendon hammer like this. Remember the principle of momentum. Mass times velocity is momentum. So we are going to subject momentum to his tendon to get a reflex. So hold it at the tip. There's a reason why we are giving a long rod. So it wouldn't make sense for you to hold it here or here, proximal. So it should be distal. Hold it like this. Don't hold it like this, or don't hold it like a pencil, like a sword. And don't flex and extend the elbow. Only flex and extend or flex and dorsiflex the wrist. So it's very simple. So I'm going to hit at the patella tendon. It's almost like I'm just dropping it. Okay, you can see. Just dropping. I'm not even swinging. So only if you see, my elbow joint is not moving. It's my wrist joint is just moving. Okay, the same thing I can do it here.
Hyperreflex,
Normal area. Okay. So you can try. Okay, exactly. Okay, try again. Now hold it deeply open. Okay. And biceps. So I want to make sure the patient is completely relaxed. So I would want to stabilize his elbow over the pillow. Okay. Biceps. So same thing. So I can look for the contraction of the biceps or the flexion of the elbow. Relax fully. Fully relax. Yes. Okay, and then the other. Relax. Okay. Okay, you can see. Okay. Can you?
Okay, sure.
I'll give you one point actually. Okay. Okay, yes, beautiful. Okay, that concludes the examination. So the summarized details will be in the descriptions, which you can look for. So you get the overall flow of the examination for thyroid. So it's important to know that it's not all about just neck examination. The relevant general examinations is a must. For example, we check for the eye, CVS, tracheal deviation, hand, pulse, reflexes, and proximal myopathy. In addition to the actual neck examination. The important thing, when you palpate, make sure you do it from behind.
I really have to thank the patient.
Thank the patient.
Thank you.
Okay, thank you. Next.
So ideally we have to perform the tracheal deviation. So do you want to do?
Sure. So first we have to properly expose the patient, so that we can get access to the
Heart.
not the heart. Sorry, it's a bit of
Heart சொன்னோனே வந்துருச்சு பாத்தீங்களா?
okay.